I just want to underline that for me this is a very big subject, and I have been allocated 15 minutes for it, and it's impossible to fully cover the technique we use in 15 minutes. But for those of you who are interested in... Sorry?
17 you can get.
I get 17, perfect. I'll take it slow then. So otherwise it's published the technique that I use in clinics of plastic surgery in 2009. So for those of you who want to read up on it, it's there. Now I think it's very important, if we're going to discuss mastopexy augmentation, to first answer the question on how to correct ptosis of the breast with implants, and mainly answering the question, when do we have to use a mastopexy and when can we avoid it? And for many surgeons it's a little arbitrary decision making, but we can make it much more mathematical. Now obviously when we see patients we know that there are severely different degrees of difficulties in decision making. So we have the patient on the left here. She has a full lower pole and she has very minimal skin excess. And that's a straightforward, simple case where anybody with a relatively arbitrary planning can get a good result. The patient on the right side here, however, she has a pseudoptotic breast with skin excess. And how do we deal with these patients? Now, the first thing we have to do is to answer the question, what about the vertical positioning of the implant on the chest wall, which is very important, and that should be in relation to the nipple complex. So very important principles for implant vertical height positioning was something I looked a lot at in the 1990s, and it's the foundation for what we call the Akademikliniken method today. And the first principle there is that if we correctly perform the breast augmentation, we actually get the true elevation of the nipple complex. The second principle is that planning on the breast is not so good because the tissues are lax and it's always variable when it comes to the planning along the meridian of the breast. So if we transfer the new nipple position or the nipple position to the midline by drawing a nipple to sternum line, this is a much better way to plan the procedure. So that's for me a very, very important line in our primary breast augmentation patients, but mastopexy augmentation and all planning procedures we do. And the third thing was that I looked at several hundred breast augmentation patients in the 90s and found that we can actually predict the nipple elevation after breast augmentation by arm elevation preoperatively. And the correct elevation is to put your hands on top of the head, which is a 45-degree elevation. So that's a very good way of predicting the new nipple position, if it's a lax breast or if it's a tight breast. So we go back to this patient. The principle for this planning is at arm elevation and then thinking about how much we want distal to the nipple projection point. Well, that's simple and straightforward, whereas this patient is totally different. When she elevates her hand, we can see that the nipple is well above the nipple projection point, but it's still a very short lower pole here. Now, how should the implant be located in relation to the nipple complex? This is just trying to depict the implant in a breast. This is an MM320 implant. And if we think about the nipple projection point on the ventral surface of the implant, the goal is to have approximately half of the implant above the nipple projection point and half of it distal to the nipple projection point. I can't shift this implant up and down to show it how it affects the breast, but I can rip off the nipple complex in Photoshop and replace it lower down. So on the left it's pasted lower, and on the right hand side it's pasted higher. And if we replace those implants in a similar way, we can see that if we put more of the implant height above our nipple projection point, our nipples will tilt down. And if we put more of the implant distal to the nipple projection point, our nipples will go up. So the goal of a breast augmentation, especially if we use anatomical devices, is to have approximately half of the implant distal to the nipple projection point. Round implant for a natural appearance, usually I put 55% distal to the nipple projection point. So the planning for a breast augmentation is here just illustrated with an 11.6 centimeter high implant. The first thing I do is ask my patient to put her hands on top of the head, and then I transfer the new nipple position or the postoperative nipple position to the midline by drawing this nipple sternum line. And then in the midline I measure as much as I want distal of the implant, which in this case is recommended to be half the height, obviously 5.8 centimeter. And then extend the line parallel to my nipple sternum line, which I call the ILP line, the implant's lower pole, and that decides the vertical position of the implant, and I have answered my first question. Same principle can be used in a evaluation if a mastopexy is possible or not. So this is just exemplifying the planning. You can see the upper left-hand corner, the patient has her hands on top of the head, and the nipple sternum line is considerably different compared to the upper right-hand side when the arms are hanging. And 3 hours postoperatively, you can see that there was a correct prediction of the new nipple position by arm elevation, and then 6 months later. Now, remember that different implant heights will be differently positioned in relation to the nipple complex. So these implants all have the same width, but we can see they have different heights. And if we think about the nipple projection here, we can see that the short height implant really should be adjusted upwards, and that comes in different relation to the submammary fold therefore. The moderate actually sits where it should be, and the round, 55% distal to the nipple projection point, should be distal there, and also a full height anatomical device. So here a patient, pseudototic patient with a short lower pole when she elevates her arm. And to get a good correction, I select the low height implant. But then to fill the lower pole, I have extra projection. And we can see on the left-hand side, preoperative when arms hanging compared to arms elevated to predict a new nipple position in the midline, and then compared to 4 hours postoperatively when the implant has elevated the nipple complex. So this is the same patient, arms hanging, the pre-op planning with the arms on top of the head, 45-degree elevation, and we can compare it to 6 months postoperatively. Now, if I had used a round device in this implant, either the nipple areolar complex will point down, or I would have positioned it far distal to the existing inframammary fold. And if I position an implant distal to the submammary fold in a case like this, what happens? Well, first of all, in a case like this, I will have too much skin. But secondly, you will have a high risk for a double bubble deformity. Now, that is the first thing to consider when we answer if a mastopexy should be able to avoid or not. The second thing we have to answer is how much skin do we actually need in the lower pole of the breast? And this is something we mathematically can calculate, because the amount of skin we need in the lower pole of a breast in a breast augmentation relates to where the nipple projects on the implant ventral surface. If we want half of the implant distal and half of it proximal, then we have to consider what I call the lower ventral curvature of the implant, the amount of length we have from the nipple projection point to the lower border of the implant, the LVC value of the implant. And then we have to consider also the amount of gland the patient has, which is actually the difference between the purple and the red line here. Why the difference of the purple and the red line? Because if you empty the breast, make a subcutaneous mastectomy, basically this purple line comes in, and therefore you want to know the difference between the red and the purple line. So amount of skin needed in relation to the implant depends on the implant base plate and the projection. So this small implant, 135 grams, that just has the lower ventral curvature of 6 centimeter. This big implant needs the double distance, 12 centimeter. And we have to think about it. And it's interesting that plastic surgery has been doing this procedure for 50 years without really considering it so much. The LVC values of implants can be calculated for every single implant. Just by measuring it on a piece of paper. I've done it for Allegan's implants, which we have mainly been used to use. Now, how much do we add for the gland, the difference between the red and the purple line? Well, I would say in a typical breast augmentation is about 1 to 2 centimeter. If you make it really simple, you could add 1.5 centimeter to the LVC value of the implant. Now that's not a very accurate way. A better way is to take the central glandular pinch and divide it by 2. But if we think of it in a mathematical way and triangular arithmetics, it's not perfectly correct. So actually what you want to know is the difference between the x and the y here. The question is, how do you do that preoperatively, which is your third alternative in planning how much you add to the LVC value. And actually you have everything you need because you have already planned the implant's inferior border by arm elevation and then predicting how much you want distal to that projection point. So you only have to ask the patient preoperatively to ask her to put her hands on top of the head and measure the convexity of the breast and what you subtract from that, the inside. And the inside is half the implant height, which is your third alternative. Now what is the importance of analyzing both the implant's vertical position and the amount of skin you need in the lower pole? Why do you have to think about both of these things? Because if this difference is more than 2 centimeters, then there's too much ptosis. You have to consider mastopexy. Or the implant is too small to fill the envelope. Perhaps you need more LVC value to really fill that envelope. Or reversely, if that line doesn't come above your ILP line, it comes distal, well then your tissue is too tight, the implant is too big for the envelope. That's why these two questions are so important to answer, both in primary breast augmentation, but also when you have patients with pseudototic situations. So when is the mastopexy indicated? Well, usually in most cases where the nipple is well distal to the submammary fold. In many secondary cases with glandular atrophy, if you're going to change the implant and there is if you put the new implant, especially form-stable implant, it will not fill that dead space. Many of these cases need some mastopexy. Could also be patient who expects and demands more nipple elevation or more upper pole filling than you can achieve with, for instance, a low height extra projecting implant. And obviously patient who desires reshaping of the nipple complex. So what about mastopexy augmentation as a one-stage procedure? Well, the advantage is obviously has high patient acceptance. There is one hospitalization, which is cheaper, but I think perhaps even more importantly is that the mastopexy is adjusted to the dimensions of the implant. That means we consider what the amount of skin we need in the lower pole at the time of the mastopexy. And if you see a lot of surgeons who actually advocate against mastopexy augmentation, especially a slightly bigger ptotic breast, and say that this should be executed very, very cautiously. Well-known surgeons like John Tebbe says, oh, you should be avoiding a big ptosis. Now, these surgeons really don't think about the fact when they do their mastopexy at the first stage, which is the most common, to consider what implant they're going to put back in this patient 6 months later. And that's something you actually should do if you do it as a two-stage procedure. Now, the disadvantage with one-stage procedures is there's an increased risk for healing problems. And a common reason for malpractice suits in many countries. In some countries it's said to be in aesthetic surgery the most common reason for malpractice. So it's more technically demanding. The preoperative planning on your surgical technique is crucial to get good results. And obviously we see a lot of patients who come and say they don't want a inverted T, they don't want the mastopexy scar, they want only the scar in the submammary fold. And you have to be able to tell them if it's possible or not. And you have to avoid these type of poor results, because this is a poorly executed inverted T technique in a mastopexy. Animation problem, muscle is not divided in the correct way by this surgeon, and the submammary fold scar is way too long. You don't need this long, this incision. If you create a small submammary fold incision and you suture it into the fold, this is the least conspicuous part of the scar. So the planning is very important. A correctly performed and planned inverted T or mastopexy, the submammary fold scar is very short and it's sutured into the fold, and it's basically inconspicuous, like this secondary side chain from subglandular to submuscular implant. Now, so in analogy with what I said, in a breast augmentation, the implant's vertical height should be adjusted on the thoracic wall in relation to where the nipple areolar complex will end up. In a Mastopexi augmentation, same principle, but we adjust the nipple areolar complex to the implant that we have selected. But same principles. So the same sort of planning, but with the big difference that we do it in a reversed fashion. So instead of planning how to position the implant lower pole, we use the inframammary fold as the starting point and then plan the nipple position. So the inframammary fold becomes the implant lower pole. So how do we use this principle in a Mastopexi augmentation? Yes, this patient is obviously very clear, very, very distally located nipples. There's no chance that you can correct it with just implants. She needs definitely Mastopexi augmentation. This is absolutely too long for the time I have allocated, so I'll just speed it up. So basically what we do is to extend our inframammary fold to the midline, and then this is just sort of the patient communication. I'll jump that. So we extend the submammary fold to the midline, and you can see this patient has a little bit of an asymmetry in her submammary fold, and therefore I will lower the left submammary fold half a centimeter, and the right submammary fold I will elevate half a centimeter, so they come in equal heights. Now I have my implant height here, it's 11.6, so from the midline approximately I measure half the height of the implant, which is 5.8. And then you have to extend the line from the sternum to the midline. Extremely important when you do that is to elevate your arms. If you don't elevate your arms, the nipple areolar complex will be way too high. So you extend that new nipple position laterally. And usually if you have selected an implant that's quite accurate for the dimensions of the implant, then it will project relatively close to the existing submammary fold. Now when you have decided the new nipple position, you check it in relation to the submammary fold. It could be above if you have a little bigger implant. It could be slightly below or at it. And then check the distance from the sternum notch, mid-clavicular line, and from the midline when you plan exactly the position of the new nipple areolar complex. And obviously these nipple areolar complex are medialized. You want to lateralize them, therefore you sign out the meridian of the breast, and that's where you reposition your nipple areolar complex. Now, what type of technique should you use? Should you use a periareolar, inverted T, or should you use a vertical technique? Same principle can be used in all of these techniques. But that depends on the amount of skin you need in the lower pole, because you have to think about the LVC of the implant, the lower ventral curvature, and the amount of gland. And then you have to stretch the skin from the submammary fold proximally. Usually a periareolar technique is not a good technique in many cases because it flattens the areolar complex and it gives a widening of the nipple areolar complex. I use it for small adjustment, but I try to avoid periareolar mastopexy in most of my cases. I think it's overused. Vertical technique works very fine. The benefit of a small submammary fold incision is you can really emphasize it with your sutures, and you can also, when you do that, get extremely good access to your area. So we have first now decided where to position the nipple areolar complex. Then we think about the amount of skin we need. We mark the diameter we need. Usually I have about 13 centimeters circumference there. And then we think about the amount of skin we need between the areolar border and the submammary fold. And that here is related to the LVC value of the implant, 8.4 for this implant, plus the tissue cover, which is 1.4. So she needs 9.6 centimeters between the nipple and the submammary fold. Well, that's from the nipple. Now you want to know the areolar to submammary fold distance, so you have to subtract what? Half the areolar diameter. That means I subtract 2.2 approximately, or 2 centimeters from my 9.4. That's the distance I need with the areola and the submammary fold. And then I mark the midline, displace the breast medially and laterally, and then I just if I need to, I take a little wedge, or I can make a vertical. Same principles, very straightforward and safe way of doing it. So basically that's the planning. Now how do you execute this procedure in a very good way? A very good way of executing it is to use your incision, but don't burn any bridges. Start off like doing it a two-stage procedure, which means that you want your implant in place first before you excise any skin. So the first thing I do is I incise my submarifold incision and one of the vertical pillars. The benefit of one of the vertical pillar is I expose the whole pocket, especially if you have a secondary mastopexy augmentation. It's so easy to get access to that whole implant and the capsule if you're going to do a neo-submuscular pocket or something like that. Always protect the nipple-areolar complex with tegaderm, so minimize contamination, local anesthetics. And then I use my submarifold incision. I cut through part of the vertical pillar, and I get extremely good access to my whole area without excising any skin. The other benefit of cutting into one of the vertical pillars is that you can really shape the breast by sutures before you resect any skin. So we do that, and you get good access, and obviously you can make your, this, as I said, it's a little bit too long. So you can do your submuscular dissection, usually dual plane 2 technique, leaving muscle distal to your nipple sternum line. Very important is to have enough muscle distal to your nipple sternum line so you don't get animation problem. You want the muscle to retract from the lateral part of the capsule, however. So let that retract, but keep it low in the midline. Okay, we skip that part. And before I put the implant, I use a quill suture here, barb suture. I suture it scarpa fascia to thoracic wall, and on the right side I elevate the submarifold, as I said, a little bit. On the other side I lower it. So I suture along the lower border there, and then I take the lateral and medial pillars and put it to the midline. So it becomes like a vertical mastopexy, but with a small inverted T. And then I do the same thing on the other side, irrigate the pocket, change my gloves, minimize contamination, put the implant in place. And then I put everything together. So now it's a two-stage procedure because the implants are in place, and then it's time to do the mastopexy, get the patient sitting up. So we always have these patients sleeping with arms along the side. And then we get the patient sitting, and I do the same thing on the other side. And very important for me is to check my markings with the patient sitting, and I use staples to reposition, see what everything is, and then I just execute the mastopexy. Very safe way, no tension in the T-junction, 3-point closure. I think that's about as much as I have. Just examples here. Obviously the same planning and technique can be used in perioral mastopexy, like this tuberous breast, or the vertical technique, as in this case. And the healing process there, 1 week postoperatively and 6 months postoperatively, vertical technique. Or exemplifying a patient who really don't want the big breast. So this is a case where we could use a round device. I use a TSL, very low projecting implant, just 2 centimeters to produce that long-term upper pole roundness. Small reduction at the same time. So this is a small round implant. Or as here, there's a bigger breast on the one side, same implants on both sides, FX410, but reduction on the left side at the same time. So it can be not just a mastopexy, it could also be a reduction. And this is the healing process in a secondary case, 1 week after and then 6 months after, where the scar is where it should be. Secondary mastopexy augmentation also. The breast augmentation in combination with mastopexy was performed in 5% of our cases, and with other procedures such as abdominoplasty here in 2% of cases. And obviously mastopexy augmentation can alone or in combination with other procedures result in dramatic changes in body image. The longevity and stability of these procedures is very good. This is 6 months postoperatively and then 7 years later, so most of these patients has a long-lasting result. Finally, I would take the opportunity to hope that many of you will come to next year's BTS meeting. This was from this year. We had a very good response. You can go to the webpage, ak.se or beautythroughscience.com, and hopefully be part of the 750 plastic surgeons that were there this year. Thank you very much for your attention.